We're going to move on to the next controversy. We need to up the ante a little bit, get a little bit more heated. I'll invite up Brian Kwon and Paul Park. We're going to talk about indirect decompression. Brian will go first. He supports indirect decompression on all your fusions. Is that correct?
All of them. Obviously, the extreme positions were set on purpose, but as we all know, it's not all or none thing. So I'm talking about indirect decompression from lateral oblique surgery alleviates all compression. Here are my disclosures. Okay, so I have two patients, Virginia and David, and we all know of Virginia and David in our practice. Around 70s, retiree, active, symptoms of classic neurogenic claudication, failed a year of non-operative treatment, and this is what their MRI looks like. Again, we see a 4-5 slip, spinal stenosis. We say, okay, Virginia, David, my recommendation is that you consider surgery. And that's exactly what I told them. And I told each of them, I'm going to do this procedure called an X-lift or a D-lift, and you're going to get pedicle screws. Virginia says, great, doc, that sounds fantastic. David says, but Dr. Kwon, I heard that I need a laminectomy. I was told I need a laminectomy. Well, okay, but I think this lateral surgery will take care of it. He insisted on having a laminectomy. Virginia's on the left, David's on the right. Surgery went great, and both of them did well in the immediate post-op period. And that takes us basically to what we're talking about. Two things need to happen when we operate on these patients, right? Number one is that we need to decompress the neural elements. It's kind of part of the deal. That's why they're coming to you. With a spondylolisthesis or with other deformities or instabilities, we have to do a fusion. So basically, if you set up a kind of a 2x2 square, we can kind of lay out what the issues are here. So yes, you can fuse. No, you don't have to fuse. Yes, you decompress. No, you don't decompress. Obviously, the ones who say no fusion or no decompression, that's a bottle of Tylenol, Percocet, whatever, and that's not even the topic of this, so we'll move on from that. Now, again, decompression and fusion, we all know. It's, basically in our back pocket, it's sort of spine surgery 101, and nobody has a problem with that. And this data goes back 30 years now. But during this same 30-year period, we have many authors who also have argued that perhaps decompression without fusion is as good, and we'll go over that data briefly. But this is the category that I'm focusing on, and its use of X-lift, right? Or D-lift or L-lift, whatever you want to call it, but basically fusion without direct decompression. So just as a matter of review, so that we're all on the same page here, we of course understand the sport data that show that essentially laminectomy with instrumented fusion is better than non-operative care. A recent AAOS review article, a very good one actually, and for some of the younger surgeons, and even, I guess I'm an older guy, it's good. It was great to review, but they clearly say we understand surgical treatment is appropriate. However, the optimal operative technique is still debated, and obviously they have A-lift versus lateral versus just a regular posterior. And of course, certainly most recently in the New England Journal of Medicine in 2016, Gogwala and Forst published a randomized study looking at laminectomy versus laminectomy and fusion, and the conclusion ultimately was adding a fusion to an individual with spinal stenosis and/or spondylolisthesis does not change their outcomes. Although I do point out, and this always gets missed, is that the reoperation rate in the non-operative group was something like 3.5 times higher over time. But it was interesting. I just happened to have the journal open, and I was looking through it, and the editorial basically, where these individuals say the addition of instrumented fusion does not create any added value for patients and might be regarded as overcautious and unnecessary treatment. It seems pretty strong, but okay, that's an opinion, right? But this is a group I'm focusing on, okay? And in fact, some of the authors are here in the crowd, and so, this is really current. This is what we're talking about. This is what we're doing right now. So, first of all, does it work? I'm sitting here telling my patients, gee, Virginia, you're going to get this cage. It's going to make your spinal canal bigger. It's going to make your foramen bigger. It's going to even make you a little bit taller. And in fact, if you look all across the board down each of those columns, now some of this is central canal area and diameter, just for the sake of space, I truncated it. But you can see really significant changes here. These aren't 7, 10% increases. These are 30, 40, 50% increases in all dimensions. And so your goal of doing a decompression, I think, is satisfied by looking at these. And these are MRI, sort of pre-post CT cadaver studies. This is the data from the Marulanda paper. Navarro Ramirez, I thought, did a really interesting work looking at foraminal volumes using a special computer program. This Harayama paper I find really interesting. They basically did 2-level XLIFs or DLIFs and did an intraoperative CT myelogram. So they compared pre to post these spinal canal areas, which I thought was really pretty fascinating. And what I really love about this figure, actually, if you look on the left on those sagittal images, you can see the buccal annulus there, and you see really sort of what I call the power of ligamentotaxis, right? You see a really great sort of flattening of that disc space and expansion of the canal. So anatomically, I feel very comfortable, I certainly feel very strongly that putting in an XLIF cage works in terms of the technical outcome of expanding the spinal canal. Well, how do the patients do? Well, do we have any data to support that? Well, we sure do. We've, again, had data going back almost 10 years now with the Oliveira paper, which I believe was with Luis Pimenta. But we have data now, spanning 8 years, I guess. The most recent one that I found was Temple. The 3 studies on the left were standalone only constructs. The 3 studies on the right are standalone with a mixture of all pedicle screws. I believe that's Pereira's study. In fact, Kai's here, and we were chatting about that. And Greg's study from 2015. But basically, the take-home message is that patients do incredibly well with this operation. You get ranges of 40 to 60% reduction in pain. You get 30 to 60% improvement in function as measured by the oswestry. Now, you look at this reoperation rate, and how I think about that, if I can frame this for you, you're not reoperating as if you're doing a revision disc because you didn't get all the disc fragment. You're not doing a misplaced pedicle screw. I've heard this mentioned a bunch of different ways, but some folks call it an indefinitely staged procedure. And I think, Neil, if I don't mind quoting you, I believe you said, is he here still or no? I believe he will actually talk to patients post-op, and if they have pain, takes them back to surgery either the next day or a couple days later. And that's somewhat common that I've heard people doing. I don't know if he still does that, but maybe he didn't tell me that, but anyways. But either way, you're doing this reoperation for the sake of really what you're doing is saving them an entire posterior operation, which has its own complications, increased blood loss, increased operating time, and many of us keep the patient in a lateral position. So other than the fact that we screw up their lordosis, according to John, we're potentially saving them a tremendous amount of morbidity. But what are the failures coming from? And again, we've had some good work on this. Greg, I think in your paper in 2015, you mentioned bony stenosis, and I probably plagiarized that image out of your paper, so don't arrest me, all right? But anyways, I believe this was several SOLAS members here who looked at about 45 patients. They had a 30% reoperation rate, but they used a fairly very stringent criteria. They looked at independent variables, multi and unilateral univariable predictors, and what they found was that bony lateral recess stenosis, again, same as Greg's conclusion, leads to high failure rate. And then a more recent study by Temple looking at 300 patients. This is a standalone paper, or standalone population, 22 millimeter cages. They had a subsidence rate of about 11%, and they used the Markey criteria, which is, I believe, quartiles of subsidence, and their reoperation rate was 6%. So here's Virginia. She came back soon after surgery. She had an episode of incontinence, and I got really anxious, so I got an MRI on her, and I was really pleased to see this and this. So I don't know what her incontinence was from, but I was really pleased about the surgery. David also came back soon after surgery, about 4 weeks, not because he had incontinence, but because he was having fevers and a draining wound. And from this one case, I was convinced that direct decompression is no longer necessary. I'm just kidding. But you know how we tend to use our bad complications. David ended up doing well anyways. He fused nicely and functionally did well. So I think ELIF performs great. it decompresses well, and we know about its historically high fusion rates. It's primarily due to real powerful and very effective disk space distraction. And I think the fusion also eliminates that constant flexion extension trauma that causes the original nerve root injury or nerve root pain. Again, I think moving forward, we all look out for bony stenosis. We look out for cage subsidence and those risk factors. I think one thing that's not been settled yet is adding a full posterior construct, i.e., 4 pedicle screws and 2 rods. And I'm guessing someone's doing work on that. I hope they are. If not, please contact me. Let's get on that, because I think that's a fairly straightforward thing that we can discuss and solve. Thank you very much.
Thanks, Brian. All right, next, Paul's going to come up here and provide a counterpoint.
Thanks. I appreciate the opportunity to be here. It's my first time at SOLAS. I think it's a great meeting. So I'm going to probably reiterate some of the literature that Brian so eloquently stated. And you made a great argument about indirect decompression. But hopefully I'll make a stronger argument suggesting that you need to do a posterior decompression and fusion. So this is the title I was given, Not So Fast, You Still Need to Open Posteriorly and Decompress. So here are my disclosures, none of them relevant. So Brian went over this quite a bit, but I think it's important to kind of reiterate some points here. So disk space distraction results in increased foraminal height. We all know that. It also impacts lateral recess and central stenosis. Just via ligamental taxis and realignment of the spine, you get your decompression. Why do surgeons like it? I personally think they like it because it's easy. You don't have to deal with the lamina. You don't have to worry about a durotomy, stripping the muscles off. A little bit of a challenge. It just adds time. We're all surgeons. We don't want to be in the OR. 5 seconds is like an hour in the OR, right? So if you can save some time, we all like it. So, and this is a paper that Brian mentioned. It's one of the first papers, actually, looking at indirect decompression by Pimenta. And it was just 21 patients with lumbar stenosis and spondylodegenerative scoliosis. And what he found on pre- and postoperative MRI measurements is that the mean disc height increased 42%, the foraminal height 13.5%, foraminal area is about 25%, and the central canal diameter, which is most important, was about 33%. So it definitely improved the caliber of the spinal canal. And these are just figures from his original paper, and you can see it's very clear cut. Brian had a few good diagrams as well, so it does work. And I'm very aware of it. Here's one of my patients, 52-year-old woman, back and leg pain, associated numbness, no more exam, refractory conservative measures, BMI of 39. It's like my mean in Michigan. I don't know what it is in other states, but it's definitely the mean for me. And she's moderately painful, 7 out of 10 pain. So here's our MRI, very, very standard. We see this all the time in our clinics. Here's her x-rays, and she's got a positive sagittal balance. And I think this is mostly functional. It's just pain from the spine level. Fairly clear cut. So what can we do? A direct decompression, which we all know how to do. LAMI, PLIF, TLIF, or just a LAMI and just standard traditional posterolateral fusion. Or we could do what Brian is arguing, a lateral with perk screws. And so this patient had a lateral perk screws, and you can see alignment's better. I think she stands more erect when she doesn't have stenosis, and some correction with the cage. And her decompression looks good. And I can tell you, pain-wise, this is her ear follow-up. She doesn't have any pain, so it definitely works. Not arguing that point. What I'm arguing, though, is does it work all the time? And that's the main issue. There are a lot of things about surgery that are variable. That's why we get complications. That's why our outcomes, I think, are sometimes not as good as we want. So if there's a variable that we can control, I really think we should, for the patient's interest, do it. And if we know that indirect decompression doesn't work sometimes, why are we putting patients through a potential second operation? I think that's the main issue. We want consistency, right? So going back to Pimenta's paper, they had a 10% failure rate. One was from subsidence, which makes sense. You lose your disc space distraction. Stenosis recurs. You lost your ligamental taxis. The other was inadequate restoration. So at the very beginning, they didn't get enough disc height restoration, okay? So these patients had direct decompression. They did fine, fusion. Okay, what else? This is a paper that Brian brought up, and I thought it was a good paper. It argues my point. They had a 29% failure rate for reoperation. Maybe 1 in 3 of patients, and bony lateral recess stenosis was the biggest predictive factor. So we have several factors now. Subsidence, which can happen, not enough distraction at the beginning, and bony lateral recess stenosis. So multiple variables where you could have a potential failure. So if it were me, I don't want to go through surgery going, well, I might do okay, or I may not. I may need a second operation. Another anesthetic, more costly system. I really think you should do what's right, right? So what do you want, a guarantee or a maybe? If I were a patient, I'd run a guarantee, and here's just an example of this. 64-year-old man, refractory to conservative measures, normal exam. Look at his MR. Looks pretty good. I look at this, I'm not really thinking lateral recess stenosis. I'm thinking more, ligamentum, flavum, hypertrophy. Really doesn't strike me. So I did a lateral at 3-4, you got disc space distraction, good. He had lateral recess stenosis. Who gets a CT on everybody to determine if they have bony lateral recess stenosis? One person in our audience. 2? Okay. Well, I don't get it. So how do you know? So there is going to be a failure rate here. So another example, 78-year-old woman, L4-5 fusion, and comes in with pain, moderate pain. And here's her MRI. Looks like, adjacent segment stenosis. That doesn't look bony to me, a little bit of a disc. So, lateral, and if you get the CT afterwards, it's calcified, so lateral recess stenosis, bony. 1 month, she's just modestly better, but I tell the patient, just wait a little bit longer, let's see how you do. She's no better at 4 months, she's in fact back to where she was, right? So I had a decompression, here's our MRI, and you can see the residual lateral recess stenosis there on the right. And at 3 months after decompression, she's fine. So if I started with the decompression, she would have been fine to begin with. So here's Dr. Kwon, pretty photogenic, looks the same on the podium. And so what he's going to tell his patients is, I recommend indirect decompression, believe it. But he knows all this data, he just presented it, right? So what he's really thinking is, this will definitely maybe work, So I think it'll work, so that's what you're telling people. So in conclusion, I think what you should do what is right, not what is easy. All right, thank you.
All right, I'll open up the floor for questions. Those are great talks.
Question for Paul. So when you do direct decompressions, do you do percutaneous screws and then a minimally invasive decompression, or do you just do it open?
Minimally invasively. If you're talking about like a case, I'd probably do an MIS decompression TLIF.
So we've asked the $10 million question, right? When do we pick a CT scan? When do we decide to preoperatively add value to the decision-making algorithm? So I'm curious, if you guys know what you know today, looking at the literature, tell me what your algorithm looks like today in terms of identifying those patients that may not fare well with a indirect decompression versus a direct decompression.
So right now I'm kind of in the mode of which patients to include. Anybody with a flexible spondy, for example, that moves, which is not, kind of criterion we all use. The one that case that Paul showed with a really hard disc, where it's probably not going to be that flexible, and I think the key is this somebody you can really get good, effective ligamentotaxis on? I think that's the first person who I'm already talking into saying, look, we can just do this with indirect decompression. So I personally tend to always back these up. I just said I never use always or never, but in this case, I'd probably say 98, 99% of my lateral surgery, I back up with 4 screws and 2 rods. I think that the key for me, again, is does it move? And it's got to have some movement, some ability to accept a cage and hold it there. So obviously, in fact, I had a recent disaster case where I was thinking the whole time I shouldn't do this. Older woman with soft bone, which I did a standalone on, kind of violated everything, and she, unfortunately did very miserably, and I had to take her back and, decompress her. So subsidence is always on my mind, and, technical, good end plate prep. But for me, it's just, is it mobile? Is it going to move? Am I convinced it's going to move?
Yep. Personally, I'm a fan of indirect decompression in spondies. In fact, I favor in spondies because of the realignment issues. When it comes to just, where the alignment is fine, I still do a lot of lamies without fusion. Adjacent segment disease is a little different issue, right? Which is the example I showed. And it was hard to tease out because it didn't look like a calcified disc protrusion. And that's where I struggle a little, because I know there's a little bit of a failure rate. And I don't know of a good way unless you get a CT on these people, and that's adding radiation exposure to the patient and the cost of the system. So I don't know. I don't know the right answer, but for spondies in particular, indirect decompression is the way to go for me. Right. It still may work, right? I mean, it's just a bigger risk if you know about it.
Kai Lam here. I just wonder whether, because a lot of these studies are radiographic and we're not looking at the patient's symptoms, because stenosis is typically dynamic, because the patient will never tell you, I have leg pain sitting down or sleeping. Most of the time they say, I walk a certain distance and I get the neurogenic, the nerve pain. So I listen to my patient, because if the symptoms are dynamic, that means I know if I open it, stabilize it, indirect decompress, the symptoms will improve. Of course, I'll correlate it with my CT scans, because if the patient has severe nerve pain, it has unremitting, does not shift, constant sleeping, sitting, etc., and the scan clearly shows, calcified lateral recess and is now decompressed. So that's what I look for. I listen to what the patient tells me and decide whether I do a direct decompression minimal invasively or indirect. So that's my approach.
Yeah, that's great.
I think that's a huge aspect of it, is just listening to the patient more than anything else.
Yeah.
I know.
Shocking.
Yeah.
That's
All
groundbreaking,
those,
Kai.
right? I know.
Going back to the
No, it's
basics.
Novel thought.
excellent point. Yeah.
10 radiographical studies or just
Yeah.
a good history.
Yeah. Right. Exactly.
So I typically use indirect decompression when patients have loss of their of disc height, significant disc collapse. I feel like I get a nice indirect decompression, and very often we get a good relief of radiculopathy. Do you guys ever do it? Brian, do you perform indirect decompression in your patients that have preserved disc height? Because I've seen a subgroup of folks out there that are doing it even when patients that have preserved disc height, relating that the lack of movement that's associated with the fusion itself, the easy fusion, right? That lack of movement then inhibits the irritation of the nerve root. But for me, I've always used it just for the patients that collapse down. I know that if I open them back up, I'm going to get it. What's your thoughts on it?
Yeah. No, I agree with you. I need to be convinced that I can make a geometric change to their anatomy essentially. I try not to take out too many tall discs, regardless.
Yeah, if they have a tall disc, I would just do a laminectomy. I wouldn't fuse.
What about, so let me see if this is also what you're thinking about, though. What about somebody who Adam's talking about, but tall disc and the stenosis isn't even that bad?
Well, that's a challenge. I tend to be pretty conservative. If there's not much stenosis, I probably wouldn't recommend surgery.
Yeah.
Well, no, it's not. It's the patients that come back. They've already had their discectomy. They've already had our foraminotomy once or even twice, and now they're coming back. And again, they've got preserved disc height. Their facets look okay, but I'm thinking, well, I'd rather not go through scar. What about lateral here? What about in that situation?
I mean, it's probably case by case, I'm sure, and that's kind of a cop-out answer.
So I do see those types of patients who they may have had a decompression, but they have a fair amount of disc degeneration in the foramen or a bit tight. If you get the history of mechanical pain, it sort of fits it. And one level disease, I've done it before, and I've had some success with that. But again, I think it's on an individualized basis. I mean, I don't think you could generalize with that.
It's a good question, though. Yeah.
Yeah,
That's a tough case.
Thanks for the great talks. It's a really good topic. I think with Kai's point about symptoms, one of the things that I like using is a weight-bearing X-ray. If they've obviously got dynamic change, that's where you would fuse. And also I like CT myelograms, standing and lying myelograms. But I think one of the things with the large patient you put up, if someone's very, very big, if you're doing a lateral approach, whether it's pre-psoas or trans-psoas, you can get a wide footprint cage, you can get indirect decompression. You can still do your decompression later through a very minimally invasive approach. But I have real concerns about doing an open posterior decompression in a very large patient, the high risk of infection. If you are going to do a TLIF, your cage is going to be at the weakest point of the end plate. So I think that we can still use a lateral approach and still do a posterior decompression. So I think we can combine all the techniques to get the best of them.
I agree. I've a few cases I've actually done that, laterals and then tubular decompression. So
One last one here.
Yep. Guys, I have a question. Brian, I saw your post-op films. They look great. I noticed your cage was a little touch posterior. Is that something you will do on purpose to try to get more restoration and foraminal height?
I tend to aim towards the back because
Towards the foramen?
Yeah, in the foramen I do. No, I do try to aim towards the back. I mean, a lot of the earlier A-lift data actually showed that a lot of the foraminal, increase in foraminal volume actually correlated most tightly with posterior disc height. So, you're constantly making a judgment call on putting it towards the, ventral side and getting more lordosis, or putting it towards the dorsal side, and it's just kind of depending on what they need. Sometimes, I think for her though, I did do that on purpose, but I tend to go middle or back.
So then my second question is, because I'm a big believer in indirect decompression as well, so what if you have more severe stenosis, central stenosis than what you had there? So sometimes we see very severe, I've done them, and patients do well. But I've seen cases where maybe not the overstretch, but just getting it back to where it was supposed to be. Maybe that stretch puts more, because of the distraction, causes the canal to compress a little more, and maybe increase the symptoms. I'm talking about more if you have more severe compression than what you had there.
Yeah, so I've had that in post-discectomy, post-laminectomy patients for sure, where that happens, and they almost have like a neuritis, like a stretch neuritis afterwards.
Right.
The earliest data I remember that came out on laterals, and I wish I knew it better, but in my head I've always thought footprint is more important than height. So I would rather compromise height and put in a larger footprint cage, either medial lateral or dorsal-ventral, than going for a taller cage. So I'm more footprint is the first priority for me, and height is the second priority. Did that answer your question?
Yeah.
Thanks.
I know I said last question, but I have one question actually, because I didn't get a chance to talk yet. But we now have a lateral solution for 5-1. So we have lateral A-lift or O-lift, and at least in my opinion, in my series, it's a totally different beast when it comes to trying to achieve indirect decompression. I mean, I have definitely a higher failure rate at L5S1, particularly for the foraminal stenosis, persistent foraminal stenosis. What do you guys think?
I completely agree, but I think it's partly because we try to overemphasize our lordosis there, so we're putting more of a hyperlordotic cage in, which it tends to narrow the foramen, if anything. I mean, that's a real issue. So I compromise. If I think it's foraminal stenosis, I don't use as lordotic a cage, and I try to put it farther back.
Yeah, I've in fact, as of late, same thing. My evolution at 5'1" is, again, I'll almost compromise on height and lordosis, and if I really need to, I make sure I really get that cage far to the back as I can.
Great. Thanks, guys.